At the outset, I'm very thankful to Women's Health Forum and in association with Delhi Gynecologist Forum, Madam Sharda Jain, who is a patron, and I'm very thankful to Madam and Madam Dr. Archana Verma, ma'am, who is a president, colleagues, Foxy colleagues, and all audience which are connected online. At the outset, greetings from Ministry of Health and Family Welfare. Today's topic is very important. North India, the key to India's maternal health revolution, and Viksit Bharat 2047. As in a background discussion, we have discussed about the maternal mortality ratio, and there is a discord and a disparity between North and South India. How North and South India are behaving, what are the issues. But before we move forward, we are a huge country and we have a very huge cohort of pregnant women in the country to the tune of 2.9 crore pregnancies every year. And we give a birth to 2.6 crore newborns every year. And we have a very huge infrastructure to handle this kind of a thing. With this background, so in coming 30 to 40 minutes, I'm going to cover about the maternal mortality ratio, what is the status in India vis-a-vis the global status, the progress, excessive sample registrations, the data which is there in the country itself, what are the important causes of maternal mortality, why North India is key, why it is called as a key to the India's maternal health revolution or success in the maternal mortality achievement, what are the key initiatives, program, what are the technological interventions, what are the latest developments to handle this discord and disparity, what are the key priorities, and what is a vision strategy for 2030, and then our midterm strategy and the Viksit Bharat 2047. So these are slides. So before we move forward, let us have a look on these slides. Basically, on the right side, I want to present that in 90s, the MMR of the country was 560, which has come down to 87 per 100,000 live births, where the global MMR was 380, and it is still having the tune of 197. What I want to tell you is that the fall by which it is happening is much faster in the Indian context for the decline MMR to the tune of 86%, whereas the decline in the global MMR is just to the tune of 48%. This is not our data. This is the estimate which has been given by the Global Maternal Mortality Estimation Interagency Group. On the left side, the trajectory shows how the MMR of the country is falling as per the SRS data from 2014, 2016, then how it has come down to 87 as per the latest SRS data, which is available, that is of 2022 and 24. And the target for the country is to achieve a MMR of 70 or less than 70 per 100,000 live births by 2030. And as of now, 6 states, they have already achieved this MMR less than 70. That is the Andhra, which stands at 35, Maharashtra stands at 37, Gujarat at 64, Telangana at 48, and Kerala and Tamil Nadu, which are hovering between 24 and 25 only. This is a background, how the global statistics is behaving, how the Indian data is behaving. So this is an important slide. As of now, the SRS data for MMR is available for 19 states only, which I'm just going to show you that the highest burden is there in the Uttar Pradesh, followed by Madhya Pradesh, then Uttarakhand, Haryana, Rajasthan, and Punjab. These are the northern states, how they are behaving in the ratio of maternal mortality. On the right side, these are the states which belong to southern part like Gujarat, Telangana, Andhra, Maharashtra, which are hovering between 24 to 64. From this slide, it depicts that the major kind of a thrust is required in the northern part of the country. Like few states or UTs which are in the northern part, Ladakh, they don't have a denominator to the tune of 100,000 live births, means 1 lakh live births, and the SRS data doesn't depict their MMR. So other bigger states, they have a major chunk for the MMR contribution, and this is how the SRS data is behaving. This is one country, two very different maternal realities which are happening. If see the red bars on the right side, these are the bigger state, the major chunk of Madhya Pradesh, Uttar Pradesh, and Uttarakhand. On the left, so national average is 87 as of now by the latest SRS. A mother in Uttar Pradesh faces more than 6 times the risk of a mother in Kerala. This is the data interpretation, how you want to interpret the 154 mmR in Uttar Pradesh vis-a-vis Kerala, which stands at 24 only. This means the higher risk, higher populous community in a northern part or in a southern part, less populous or more infrastructure. So in the coming discussion, we will see what is the difference, how the difference. If we see these bar, I just try to do a comparison between SRS of last, that is our 21 and 23 reference period, with the SRS 22 and 24 reference period for the maternal mortality ratio. The gains which we get in the southern part, they are neutralized by the northern parts. If rise is happening in a MMR in a northern part, or the rate of decline is low in the northern part, and the decline of rate is high in a southern part, they both compensate, and the overall maternal mortality is not falling to the tune which is it is expected. They have a worsened with Jharkhand up to 28 points, Uttar Pradesh up to 3 points. On the upper right side, these red bars, they say the point which has increased from the previous SR to the current SR. The lower one, the greener one, these are the 10 states. With the improvement has happened, there is a fall in the point, 0.6, 0.7, 0.8 in MMR. So there is an overall compensation and overall stagnation of a MMR, which is happening from 88, 88, and 87. So why does the North India decides the national outcome? There are three pillars to that. One is a bigger states. They hold the India's largest and youngest cohort of women, which are in a WRA, the reproductive age group. Their outcome moves the national MMR more than any other reason, because they have a weightage in terms of a huge numbers, in terms of a huge cohort. So they decide how the MMR of the overall country will fall. Then second pillar is a demographic dividend runs through them. That is a Viksit Bharat depends on a healthy, productive workforce. A high proportion of that workforce is born in these states, like in a bigger state like UP, Rajasthan. So these are the bigger states which have a productive health workforce or a productive community. The younger people, adolescent people, and the maternal survival is its first condition to have a healthy workforce. Third pillar is a arithmetics of the SDG targets. India is committed to reaching the SDG target of MMR below 70 by 2030. The focus is on prioritizing the northern and the central high MMR states under Suman Roadmap 2030. This is a recent development. Swashan roadmap has been structured, has been devised for the country, how the country MMR needs to be brought down, what are the strategies, what are the steps, what are the action points, what are the actionable points by each state and by different stakeholders. This road plan has been already launched recently, and there's significant share of national live birth from these states. So we'll discuss all these things. Here I want to show you what are the important causes of maternal mortality in the country itself. If we see the SRS data of RGI, with current status of 2 years back, mostly the causes remain the same. The most important is the hemorrhage, the sepsis, the abortion, the hypertensive disorder. Only the percentage is changing, maybe 5 to 10% of these different permutation combinations they are happening. But by and large, the most important causes like hemorrhage, the postpartum hemorrhage, or abortions, or obstructive or prolonged labor, infections, antepartum hemorrhage, hypertension, causes remain the same, only the proportion is changing, which also varies from the state to state. Different in northern part, the causes of maternal mortality, they are different in the southern part, and in the mid country, their causes are different. But as a policy maker, as a national program manager, most causes of this maternal mortality are preventable if the evidence-based safe practices, they are institutionalized by all healthcare givers in the country, by all healthcare facilities, and whosoever is the stakeholder, whether in the public system or in a private system, they all contribute to this kind of effort to bring the maternal mortality ratio in the country itself. Why North India is key for the maternal health revolution? The India map depicts itself. The bigger states, 154, that is that is Uttar Pradesh, like Punjab, Madhya Pradesh, all they contribute to the major chunk of antenatal care, major chunk of total deliveries to the tune of around 40 to 45%, like UP, Uttarakhand, Punjab, Rajasthan, and Haryana. These are the recent data, and the demographic and the social discourse comes from these bigger states only. And there is a second important is a high prevalence of anemia in the pregnant women. If I show the NFHS data, this is hovering between 45 to 56% for the anemic mothers in these bigger states, and they decide the bigger cohort. Then availability of a doctor in hard to reach or difficult areas or in a rural area, that is a third important pillar or a discord which is happening, and high maternal mortality ratio coming from these states itself, and the largest share of India's working age population, a lot of migration for the purpose of earnings that also happen in the northern part because of from the northeastern part because of a kind of a domestic and the job opportunities which are available. Population into the pockets, maybe in the form of JJ cluster, in there are many pockets, and in the want of a search of a job. And this is these are the major factors which prevail over the high proportion of maternal mortality. And the tertiary care institution where referral from the nearby states in and out of migration. Like if I give an example of a Chandigarh itself, there is a migration, there is a referral system from Haryana itself, from Jammu Kashmir, from Himachal Pradesh, from Punjab itself. And all those maternal morbidity, they clutter itself in the Chandigarh itself, though the population of a Chandigarh is very low. So such kind of a geographical variation, they do happen in the country itself, which causes a kind of a variation about the burden of morbidity in the country. To handle all these things, whatever the issues and challenges which we have just discussed, there is a 360-degree approach to handle and improve the maternal mortality in the country itself. And these four pillars, which are those four pillars? One is a service provision. How the government of India, how the program is providing service to the client, to the last mile approachability of those services is there in the country. Second, in the infrastructure, upgradation in terms of infrastructure development, like maternal and child health blocks, the first referral units, the delivery points, the obstetrical HDU and ICUs, the birth waiting home in the difficult areas where the mother can't travel immediately, maybe 5 to 7 days. She comes near to the health facility with the caregiver, stays there, and when the need is there, then near to the expected date of delivery, she is already near to the hospital or the health facility itself. Service provision in terms of a JSY, JSSK, the Surakshit Matrata Aswashan, the Pradhan Mantri Surakshit Matrata Abhiyan, the extended PMSA for high risk pregnancy cesarean section. Where there is a need, please go ahead with the cesarean section, but don't do unintentional or unwanted cesarean section. So village health and sanitation nutrition days, which are celebrated for healthy ANC checkup, then IC, ambulance services. The third pillar is a training, the capacity building. Our healthcare providers should be well tuned with the latest kind of information for skill birth attendant training, whether it is a skill lab kind of a platform is there, whether the midwifery kind of a healthcare workforce is required in high case load facilities, the Daksh or a Dakshta training for the skill-based training for the healthcare worker, medical officer, the staff nurses, whosoever is engaged with the maternal health, then is a life-saving anesthetic skill, the comprehensive emergency obstetrical care or a basic emergency obstetrical. So all these kind of a set of a training or capacity building, they do exist in the system itself to strengthen the healthcare system. The last pillar is a community participation. In a public health intervention, no program can be successful unless we have a community party. This means the communitization. How you want to engage the community in rural area, hard to reach area, in a tribal area. The one is a Surakshit Matra Aswashan volunteer scheme we have. Then is a mother's picnic. Bring mothers together to those mothers who have already given to the birth, so that they acclimatize to the birth waiting areas and where they are going to deliver. That reduces their anxiety, builds the confidence, and they know at the time of need where I have to come. Then counseling, the health counseling, the nutrition, the sanitation, All these pillars in terms of a service provision, the infrastructure, capacity building, and community participation, all these pillars in 360-degree is an approach to reach to the Viksit Bharat 2047 and to reach to the target of SDG. This slide shows how the different umbrella of services or program they do exist in the country for the preventable causes of maternal morbidity, mortality, and the newborn mortality. The oldest one program for last 20 years back, which started the Janani Suraksha Yojana, which is a cash-based incentive program where you bring and motivate mother to come to the health facility. At least if the mother is to the health facility, all things they can be taken care of in terms of high risk pregnancy, any complication which is happening. Second is, if she has reached to the health facility, there should not be any pocket expenditure from her or her relatives pocket. That gives strength to the Janani Shishu Suraksha Karikram, where whether it's a normal delivery or a cesarean section or till 1 year of age of a newborn, all facilities like diagnostics, like food, like drugs, the transportation, they should be free, and there should be a single zero out of pocket expenditure. Then is a Pradhan Mantri Surakshit Matata Abhiyan, that is a high risk pregnancy detection in the second trimester onwards. Then extended PMSA means then you need to have an extra ANC checkups for the high risk pregnancy. Then midwifery kind of a new initiative in the country itself. Then optimizing the postnatal care. Where there is a need, please go ahead there. Where there is no need, do counseling and trial be given for the normal deliveries. And the Suman Roadmap 2030, we have already drafted a roadmap to achieve maternal mortality less than 70 by 2030. So what is the JSY basically? This is a safe motherhood and conditional cash transfer scheme which promotes the institutional delivery, and it was very successful when the institutional delivery 20 years back was 50-60%, which has reached more than 98-99% institutional delivery as of now in the country itself. Kind of a cash incentive which help us to compensate for the wage loss of the caregivers, giving a good nutrition and food to the mother if the cash incentive is given for the institutional delivery. Even if some pockets of home deliveries they are there, still that cash incentive is given to the home deliveries also, so that at least they can also have a nutritious. Almost 1 crore beneficiaries of those different parts of the pocket of the country, they get benefited through the JSY scheme. Second scheme, as we have discussed, free and zero expenses during cesarean section or normal delivery, free drug, diagnostic, diet, transport to and fro, free blood, no user charges. Almost 2.5 crore beneficiaries, they availed this kind of services within the healthcare, public healthcare system in the country for the newborn as well as for the mothers, so that there should be a zero out. Third very important pillar is how to reduce the maternal mortality ratio in the country. Best opportunity is to detect high risk pregnancy, because these are the mother, not the equal or equity. Equity is more important. Those mother who need more kind of care in terms of high risk, they need to be segregated. They need to be identified very timely. What we in Vasaz is that on 9th of every month, we should have a PMSMA session, which should be done by some DMOC trained doctor, CMOC trained doctor, government OBG or a DGO, or in some areas, the Foxy colleagues, which they donate 1 day for 9th of every month to have a healthy checkup of a mother for capturing or picking up of those high risk pregnancy, and then getting those investigated for the requisite test wherever it is required. And then we have a screening of 25 high risk pregnancy, which we can. High risk pregnancy is being detected. What next? Basically, in a program, at least we envisage that at least 4 normal ANC checkup should happen. But in second trimester, suppose somebody is identified a high risk pregnancy, we have envisaged that 4 extra ANC checkup needs to be done for that mother in terms of by the next higher facility. And for that, linking to the next higher facility, that is the first referral unit, and then incentivizing that ASHA, that is accredited social health activity, who will accompany that high risk pregnancy to the FRU, your next financial incentive, and also giving some kind of financial incentive to the high risk mother who is traveling for getting a checkup at the next higher facility. And once we have a healthy outcome at the 9th of after the 9 month, and that HRP is having a healthy outcome at the end of 45th day of post delivery, that Asha also gets some kind of a 500 incentive for reaching to the logical, positive, healthy conclusion. By this scheme, almost 7.8, around 8 crore pregnant women, they have got such kind of a benefit, and through which we are able to detect almost 12 million, 1.2 crore high risk pregnancy, and who got a timely care through that. And the literature percent of ENC should have high risk pregnancy, and they need to be minimum captured. And this kind of message we have given to all bigger states, smaller states, that start increasing the HRP deduction. If the HRP is deducted timely, we have a control over that mother to reach to the healthy outcome, that in terms of mother and newborn. Overall umbrella of this program is a Surakshit Matritva Ashvasan, that is an initiative which is aimed at zero preventable maternal and newborn death, dignified, respectful, quality care, no denial of services. Here we give a kind of a notification of a human facilities. There is a level care system or a secondary or a tertiary level system. We given them as a BMOC or a CMOC or a basic Suman certified facility. If you are Suman certified facilities, you have a kind of a citizen charter that minimum kind of these diagnostic services, they need to be available in those facilities. And there is a community participation in the terms of a Suman volunteer, is 1,000 incentivization first responder maternal death. We don't want to conceal the maternal death. Even a single maternal death needs to be identified, need to be investigated. What went wrong that we have lost that mother, and what can be in future can be done to prevent that mother. And through this, we have almost 1 lakh health facility which are super quality healthcare system in terms of CMOC, BMOC, or basic health facility. Another pillar in the program which we have anchored is a midwifery initiative. These are not the DIs or basically uneducated people. These are well qualified GNM, the nursing professional or a BSc nursing professional, who have 18 months nursing a kind of a training, who have a leadership quality for the normal alternate birthing experience, which are as per the International Confederation of Midwives, means as per the ICM guidance, they have that competency skill to take care of that. And these MLCU, the midwifery-led care units, the government of India give a kind of a funding to different states where the high case load facilities there. Suppose there is some community health center or a district or sub-district hospital where the plenty of deliveries they are happening. So we want these normal healthy deliveries. They can train after BSc nursing or GNM for 18 months for handling those normal deliveries only in different alternate positions with the respectful maternity care, and giving a care companion, kind of a delivery companion at that time. We have almost established 8 national midwifery training institutes where we produce midwifery educators who further teach in a state midwifery training institute, which are around 34, 35, where this midwifery code that we call as a NPM, that is a nurse practitioner midwife, these are working. This is another pillar which is very healthy, which compensates the workforce which is actually required for handling of a normal delivery. Then is a care of postnatal mothers. Data, if you see the WHO data during intrapart and during delivery, almost 50% death, they do happen during that time. And then for first early 7 days, almost 25 deliveries, they land up in some kind of a casualty. And then from 8th day to 42 days, again a 24%, which are the high risk pregnancy, they land up in kind of a casualty. So handle these things. We have envisaged that at least 6 home visits to be done if the institutional delivery has happened by accredited social. Have taught her what are the warning signs in postnatal period, to capture those warning signs during the postnatal period, to capture and bring those mother to the health facility. So this is another. And if the home delivery is there, the 7 visits they have been envisaged, and there is a kind of incentive is attached with that, so that Ashas, they do perform. If they perform, they get an incentive also. They get an incentive or that 250 per high risk postnatal mother after 45 days of delivery, after confirmation of medical officer or ANM. So such kind of a structured mechanism, they do exist to handle such kind of a high state for that. Beside that, there are technological interventions we have introduced. We were discussing the PMSMA. There is a mechanism for sending the SMSs to the healthcare worker, the ASHA, the ANM, that particular mother is identified as high risk pregnancy, and you have been registered as a high risk pregnancy, and this facility is tagged with you. The same kind of a message that goes to the ANM also, that this mother has been registered a high risk pregnancy in your catchment area, and this is the FRU attached with that. Then established maternal child tracking facilitation center where the calling system is there. Once we have a RCH registered women, they have been registered, then the teleconferencing call, then that whether you are taking iron, folic acid in time, whether you got a timely ANC checkup, you have been diagnosed with the high risk pregnancy, whether you are being attached with the next higher facility. So that is there. Then is a Suman helpline with the grievance redressal mechanism. There is a toll-free number that do exist in the program itself. Then is a Janani portal, that is a new recent RCH2, RCH 2.0 portal, where we want to capture life course approach from adolescent to the newly wed mothers, and then to the pregnancy, newborn child, and then individual beneficiary through the Janani portal, which has been launched recently last year, which was in pilot, now it's full-fledged in the country, where the name-based tracking is required for that. And then is a maternal, perinatal, child health surveillance response system, where each maternal death need to be reported, captured, line listing is required, what were the causes, which health facility, that is also being captured in digital mode. And all these portals, they have been integrated to the Swasth Bharat app, where through the login of single login of healthcare worker, they can see the data of different kind of parameters. So with this background, now we have given a roadmap to the country in terms of Surakshit Matra, the roadmap, Suman Roadmap 2030, which has been launched on 29th of June 2026 by our Honorable Health Minister of the country, in the presence of various health minister of different state. This gives a direction, and this gives a kind of a strategy that how to provide quality, equity, and continuity of the care, so that we reach to our established predefined targets of less than strategic framework with the life course approach, which has been given with the added point of pre-pregnancy care, where every family wants to plan their pregnancy. If they want to plan their pregnancy, and let us give time during the pre-pregnancy care itself in terms of any kind of hypertension, diabetes, non-communicable disease, lifestyle, smoking habits, any nutritional deficiency, anemia, whether requirement of folic acid for preventing the neural tube defects. So all those parameters, they have been envisaged under this Human Roadmap 2030, which has been just launched in a kind of a multi-pronged framework for life course approach, and promote the convergence of newborn, child health, nutrition, climate change, family planning services. The family planning services is not for controlling the population now. The concept has changed. Too many pregnancies, too close gap between the pregnancies, and that all leads to a kind of a increase in maternal morbidity, which may lead to in a unhealthy kind of a practice, leading to abortion, which can lead to maternal mortality. So healthy timing and spacing during the pregnancy is required. That is why this the newer contraceptive which has been added in the program, let it be a subcutaneous contraceptive injection or intradermal implants, which work for 3 years. So that new technology has been brought in the country, new programs they have been brought in the in this Suman roadmap. There are two kind of strategies are there. Strategy A covers 13 high focus states, which majority fall in the northern India. These 13 high focus states means they have an absolute high number of maternal death or high number of maternal morbidity which is happening. So there is a strategic approach to handle those identified districts and the states, how to bring down the maternal mortality. Let us go to the block or panchayat or the sub district level to identify those mothers and give a strategic direction. Second strategy is a strategy B. Whatever the gain in the southern part of the country or in middle part of the country, where already we have achieved the sustainable development goals, we need to maintain and sustain those goals. So there are two kind of a dual strategy approach which comes from these high focus states, which we have identified 130 districts where actual problem lies. Not only the country itself, we have identified 13 high focus states. Then we further identify 130 districts also where actual problem exists. And these 130 with a composite index where we have taken what is the percentage of first ANC, 4ANC, what is the prevalence of anemia, what is the prevalence of a cesarean section, what is the prevalence of high risk pregnancy, what is the number of institutional delivery. So we made a nine indicators, put them in a matrix, done a composite index, and we have devised these districts where the actual problem lies. We have a learning that mother can be a normal during 7 months. She is not a high risk pregnancy, not captured in first trimester or in a pre-pregnancy care or in the second trimester. But suddenly in 8 and 9 months, she becomes high risk pregnancy. What to do? For a healthcare system, as of now, that was a normal pregnancy. So more extra visits to capture the high-risk pregnancy by the accredited social health activists in the 8 and 9 months, and then incentivizing that mother for the local transport to reach to the next higher facilities, because transport remains a kind of a barrier in a hilly or in a tribal or in a hard to reach area. Timely transportation of pregnant mother is very much required. Financial support, infrastructure strengthening in these 13 high focus state in terms of HDU, ICU, which are, and then building and constructing the MCH blocks. A lot of almost 600 MCH blocks they have been given to the country, dedicated for the maternal child health. And then is a strategy for the whole of the country. The new pillar is a pre-pregnancy care. Now each day we want to plan. The couple has wanted to have a no child or want to have a one child. Even if they want to have one child, why not to plan that even a single child? Then there is a role of pre-pregnancy care to capture so many things during the adolescent period and a newly-wed couple. And even if you plan the pregnancy before that, what are the barriers? What are the negative points which need to be taken care of? That is a new pre-pregnancy care strategy has been given in the program in Suman Roadmap 2030. The mother's picnic, where the mother who already have experience of giving birth, they meet to the newlywed mothers who are just pregnant now. And then there is a learning, there is a peer learning, and learning the healthy positive aspect. Then non-pneumatic shock garment, which has been given in the program. We are giving a funding to different states that buy those pneumatic garment, anti-shock garments. Once you are referring mother in a shock, in a high-risk pregnancy or during hemorrhage or any kind of a complication, give that garment, transport to the next higher facility so that we can take care of those complications. Optimization cesarean section guidance for that we have given to the states. Suman Panchayat, this is a new concept where we want to celebrate the Suman Panchayat in terms of kind of in-kind awards. If that Panchayat is maternal mortality in that panchayat, we want to incentivize not only the maternal mortality, there is no death of a newborn, there is no infant mortality in that area. The measles rubella coverage is more than 95%. Bird doses they have been received. The family planning services, they are well accepted. So we want to acknowledge those panchayat. This kind of a concept we have given to different states so that the program reaches, the demand is being generated from the village itself, from the panchayat itself, from the block itself, not to talk about the averages at the state or the district level, to the panchayat and the block level. And we want to own those averages, and we want to really want to hit to the highest pregnancy in the field itself. Then is a digitalization labor room high risk pregnancy, digital partogram, and then reading and the capacity building of those healthcare worker for detection, digitalization of labor rooms, and use of AI. This guidance has been given to all states. Then Samagra Shishu Bal Swasthya Karyakram for 8 to 9 visits for the newborn baby, which are high risk, whose birth weight is more than less than 2.5 kg. There are different kind of a package for a home visits. If the weight is more than 2.5 kg, less visits are required, but that is an important part. Anemia being a major problem. Earlier we are having a 6x6x6 strategy. Now we have added the newborns also who are anemic. So now the recent strategy under Anemia Mukt Bharat Abhiyan is 7 by 7 by 7 study. One more beneficiary has been added into that. The climate, basically, what is the impact of a high temperature, air pollution, air quality to the maternal health and the newborn child. How it is impacting the maternal morbidity. So we have a device, a protocol, the kind of a guidance for the climate responsive action plan for the maternal health in the country itself. Then mentoring, monitoring, and review mechanism which exists in the country itself. So key priorities, if we summarize the key priorities which come in the program is that now is a foregoing is a implementation of Suman Roadmap 2030 with key maternal health program initiative, which we have just discussed. Then is an important pillar, the referral and emergency obstetrical care. That is another pillar where we want to give a kind of a financial aid to those mothers who get a transport from off its own, though we have ambulance 102, 108 system, but still that in hard to reach area, in exceptional areas, we have a provision for that also. Then prioritizing the underserved geographies through targeted district action plans. We want to have a targeted district action plan from panchayat, block, and district level. We have a national plan, we have a district plan, but now we have gone till the panchayat to have a very multi-pronged action plan at the panchayat or the block level itself, and then ensuring that 100% maternal death reporting, review, and corrective action timely. Then operationalization of 24/7 the first referral units and filling those HR gap, leveraging the digital platform, universal identification of high risk pregnancy. Earlier it was just to share that now the system is capturing, some of the state they are capturing 20%, 17%, 15% of high risk pregnancy, and then attaching and then tagging to the next higher facility and to the healthcare worker having a healthy outcome at the end of 9 months. And the quality of care in terms of NQAS certified facilities. Now earlier we were having a Laksha labor room quality for maternal OTs and the labor rooms. Now that has been subsumed in the NQAS facilities only. A facility will be certified as an NQAS only once she or that facility fulfills the criteria of a quality for the labor room and the maternity OTs itself. So this is a roadmap for a Viksit Bharat move in future. What can be a future vision for that? So first is the Sumna Roadmap 2030, where we want to achieve the SDG target of 3.1, having a maternal mortality less than 70 by 100,000 live births. So we already on track, and because I have shown that 86 and 48%, how the trajectory is falling. And if we give it this trajectory, we are pretty sure that by 2030 we'll be able to achieve a target of that 70. Then after that, what will happen? We need to maintain and sustain. Then second part from 2031 to 35, for coming 5 years, we have a plan to close the state gap. So what can be the vision? Every state below the national average is high priority district coverage. We need to prioritize districts and block who are below the national averages and maintaining, sustaining whatever gains which we have achieved. And then from 36 to 47, in the 10 years, develop national standards basically in terms of a single digit maternal mortality ratio, universal skill and respectful birth care, and zero preventable maternal. There are causes which cannot be prevented, but majority they can be prevented. We need to focus into those, because now there is a continuity of life. Basically, there is a continuum of care. There is a life course approach which start from the pre-pregnancy care, which start from identifying those risk factors in the before the mother becomes pregnant. Once she is pregnant, there is a series of activity which can be taken care of once she is pregnant, from ANC, 4ANC, HRP, PMSMA, nutrition, family planning, quality care during delivery. Once she is delivered, then there should not be any penny being spent. And then high risk capturing in the postnatal period, then newborn also till 1 year of age, and those newborn, then the vaccination of program which we provide 11 vaccines for 12 vaccine preventable disease. Recently we have introduced HPV vaccine, that is in the campaign board as a single dose schedule, Gardasil single dose schedule, and we have targeted 14 years of cervical cancer. And once these new girls they become adolescent, again that life cycle approach start for the nutritional aspect, for anemia, the deworming, and then those adolescents again they become the mothers, and this is how the cycle will move on. So we have a life course approach as of now for that. And beyond 2030, the strategy for Viksit Bharat 2447 will be once the SDG line is crossed, the goal shift from preventing death to the guaranteeing the quality, dignified, and equity in every birth, universal quality of care. That is a big area where accredited labor rooms, assured blood and anesthesia, respectful maternity care. Then professional workforce, maintaining and sustaining. Then midwifery cadre need to be there with their skill certification tied to the accreditation certificate, lot of digital and data backup, lot of AI use for prediction of morbidity and mortality, registration, investigation, surveillance, focal point. So that will be a kind of a futuristic move forward, use of IT in a futuristic program, then held across the life course. That life course approach need to be maintained and sustained in terms of adolescent, nutrition, anemia, delayed marriages, family planning, and all these are the social determinants beyond health system. Then financing means the program is there, which is being funded by the government of India or a state government for all logistics or diagnostics or kind of drugs which are being required for whether they are high focus state or low focus states, or whether they have achieved that. Gains need to be maintained and sustained. And equity as a test of success, the equity and equality is there. The equity need to be focused. Who needs more, they need to be given more, and the gap between the best and worst, this is also a way forward for the program itself. So in my conclusion, so maternal survival is a key which start from childhood or with pregnancy, pre-pregnancy care or adolescent, which will lead to healthy mothers and healthy children. We will be having a healthy workforce. We need to empower the women of the country in terms of the service delivery, in terms of a kind of a workforce which we give in the country, which will help us to have a very developed and equitable nation in coming years. So healthy mothers, empowered North India, Viksit Bharat 2047. This will be a way forward for a future strategic direction. So thank you very much. I stop here only.